My name is Scott Celinski. I'm a surgical oncologist and a biliary surgeon at Baylor University Medical Center in Dallas. When should staging laparoscopy and/or biliary drainage be considered preoperatively for patients with pancreatic adenocarcinoma? These are really two separate questions when it comes to staging laparoscopy and preoperative biliary drainage, and we'll address them separately. For staging laparoscopy, there are two potential times to be doing a staging laparoscopy. Number one would be prior to neoadjuvant therapy, and number two would be prior to plan for a definitive resection. When it comes to considering staging laparoscopy before neoadjuvant therapy, this is relatively simple to add on at the time of port placement, and in the setting of clinical trial options can change the patient's ultimate treatment plan. In the setting of not having clinical trial options for stage 4 disease, the treatment is generally going to be the same. In 2020, standard therapy for metastatic pancreas cancer or neoadjuvant would be gemcitabine or FOLFIRINOX. In our institution, for neoadjuvant therapy, we will routinely do a staging laparoscopy because if we find stage 4 disease, we have clinical trial options for these patients. Another advantage to a staging laparoscopy before neoadjuvant therapy is to change and manage patient expectations. We know if they have stage 4 disease, we are not looking at a curative treatment plan, and we can establish this earlier with the staging laparoscopy. When it comes to prior to resection, we have a little bit different thought process. The reason for performing a staging laparoscopy really comes down to the unreliability of imaging in detecting peritoneal carcinomatosis. And pancreas cancer is notorious for spreading with peritoneal carcinomatosis. No matter what your imaging modality is, CT scan, MRI, PET scan, they miss the majority of small volume carcinomatosis because imaging modalities require three-dimensional lesions in order to detect them. And early peritoneal carcinomatosis is essentially like paint on the peritoneal surface, and so is not picked up by these by scans. Even in retrospect, when you find it and go look specifically in that spot, you can't see these on scans. But if we stick a camera into the peritoneal cavity and look around, generally these peritoneal carcinomatosis is big enough for us to see with our eyes and do biopsies, but too small to see on imaging. So in the setting of doing a staging or diagnostic laparoscopy prior to resection, our goal here is to avoid a non-therapeutic laparotomy, finding peritoneal carcinomatosis in this population that has an elevated risk. The two general institutional approaches are going to either be routine laparoscopy or selective laparoscopy. The selective institutions generally will take the higher risk patients for developing peritoneal carcinomatosis and do laparoscopy on them. This would involve patients with large tumors, significantly elevated CA19-9, or pancreas tail lesions. Our institution falls under the routine category because there really is very little in the way of additional time added by doing a diagnostic laparoscopy prior to resecting somebody, and we can send them home the same day if we find metastatic disease. When we look at the question of biliary drainage prior to resection, studies have routinely shown that preoperative biliary drainage increases the risk of complications in patients with pancreas cancer. This is excluding patients with significantly elevated bilirubin to start off with that are going to be at increased risks for surgical complications due to liver dysfunction from a significantly cholestatic liver. But the majority of patients that are potentially resectable that we see come in with bilirubins in the kind of 4 to 9 range, which generally are going to do better if we are talking about upfront surgical resection without biliary drainage. When we talk about the complications related to biliary drainage, most of them are going to be infectious, involving cholangitis from the manipulation of the biliary tree, and then increased risk of surgical complications, especially infections, because we're taking sterile bile and compromising the sphincter of Oddi with the stent, allowing bacteria from the GI tract to enter into the bile, and it becomes a contaminated field. The other issue that we run into is some patients with biliary drainage end up with complications such as pancreatitis, and on rare occasions, patients who are potentially resectable can end up not making it to an operation because of the severe pancreatitis that they developed. So when we talk about whether or not we do biliary drainage, ideally in somebody who is potentially resectable and going to go for upfront surgery, we would not end up doing preoperative biliary drainage. In reality, at least in the United States, the majority of patients who have a pancreas cancer in the head of their pancreas who present with jaundice have already seen a GI doctor and had a stent placed before they end up with a surgical consultation. But ideally, the patient would see the surgeon before getting the stent placed in order to make decisions. When we're dealing with patients who are going to need neoadjuvant therapy, it becomes a different story. And there, these patients do need preoperative biliary drainage because it's really pre-chemotherapy biliary drainage. And by normalizing their bilirubin, we have more options for our chemotherapeutic treatment, and can get them through the multiple month period before they get to an operation. In this setting, generally, we would prefer to convert patients who have a plastic stent to a metal stent, because this has a decreased risk of occlusion and cholangitis, and can make them get through their chemotherapy with less complications.